let's move on to our last topic by Dr. Luis for basic part. He also the cost director of the Neuro AMC. He's a neurointerventionist from Madrid, Spain. He will give a talk on endovascular management in middle MCA aneurysms, part 2.
Okay, I like to try. Is okay?
Yes.
Yes. Thank you very much, every professor to come every week to this Neuro MSc. Just a minute because it's just a minute. This is not the first. Is not the first slide. First slide is this. Okay. I like to present some examples where it is my experience and my critical point or difficult to treat it, this middle cerebral aneurysm. In our experience, I started with coiling in '92 at the same time of Gudigliemi, and I am very happy with the coiling to the aneurysm, but the problem is the recurrence. Also, what time I treated the aneurysm with the PGLA material, or PGA is the matrix, and this material have a very high recurrence of aneurysm because have a thrombus at the set time you place the coil, you produce a thrombus, a fresh thrombus in sac. Also, I have experience with fevered coils with at the beginning is Dendron Company. Now is I think is Medtronic. In July 2005, and the difference of the fevered coils is the material is nylon, and this nylon produce aggregation, plaquetted aggregation in the sac. And this is the only reason is different results to another course. Dr. Henkens in Essen, now is in Stuttgart. Professor Hans Henkens have a lot of experience of this fever coils, but I don't know why the industry don't like to take again this material. Don't have many possibility to have these devices. I don't understand what is stop. Probably is the economical reason. This is one case treated in 2005, middle cerebral arterial aneurysm. I treated in acute phase, 59-year-old, only 2 coils, one basket with Tetris and one fiber coils. This is the time of the intervention. And after embolization, 12 days later, the control is totally occluded. In my experience, 90% or more, 95% of the patient is treated with assisted balloon remodeling. The reason is your possibility to protect when you introduce the coil to the rupture, and the second is more easy to packing the aneurysm. The most important to have a good result and stable is high packing of the sac. About the maximum is 50% of the surface. It's not possible to pack in 100%. Sometimes you are inside the coils, your flow is more flow. It's very difficult. This is the reason I use the balloon to have a dense packing of coiling. The balloon is placed in one or two branches. It's possible to change the branch, and the idea is to use the maximum number of coils. This is the control, and this is the standard result after embolization. But sometimes these patient examples come in emergency for several headaches, many times in the hospital, not bleeding, but have at least middle cerebral aneurysm. This is oblique projection, superior branch, inferior branch, aneurysm. But the problem is inside the sac, you are the branch. And this is difficult to surgery, in our opinion. And to start the treatment, I put the balloon remodeling. You are a loop in sac. I inflate the balloon distal in M3, and then with the balloon is inflated, I remove to have a good place to the catheter or coil. I coil in the aneurysm. Also, a second balloon in the inferior branch, superior branch, inferior branch. But anytime when deflate the balloon, the coil going to the neck and close the exit branch. This is the reason which is treated by double stenting. One is superior branch here, and the second in the inferior branch. And jailing. Sorry. This is the stent, superior, inferior. And then I treat it with coiling, packing. And this is habitual technique. Sometimes you are difficult to see this lenticulo-striate artery, but it's external. It's not medial. And don't have symptom, the patient. By coiling, this branch disappear, but the patient don't have a symptom. It's asymptomatic, This is the control. In lateral view, and good flow, distal flow, and size of the vessel. Asymptomatic. But sometimes with the manipulation, the problem is the thromboembolic migration. Several distal to treat it is or several distal thrombectomy with many branches with a balloon, stent retriever, or aspiration. This is small aneurysm, bifurcation. This is work projection. I place the balloon in superior branch, coiling, and inferior branch and coiling. This is the result, but in late phase have some stenotic or diminution of flow in this branch. Look, after 20 minutes, and then you don't have vascularization in this part, in motor area. Don't have very, this is ischemia in this region. Don't have good collateral circulation. And treated with a balloon and aspiration. This is another case. This middle cerebral aneurysm also have a loop to go in distal part. And then place the balloon, place the coils, but after procedure have reduction of flow on this part. And the reason is some compression in this part of the vessel. Angioplasty here, but also have a small thrombus in this part. And many manipulation to open this vessel. We are also early venous pathway. Another ischemia from this branch. I very be careful to check every region after finish the procedure to treat this. You are early vein, angioplasty, and final result, you are a good circulation, also in this branch, no ischemia, and this is the control of aneurysm. only some subfusion of contrast and small distal ischemia asymptomatic. But sometimes it's possible with the manipulation also rupture the aneurysm or rupture the middle cerebral artery. And this is a case with endovascular rescue. The main cause of break of aneurysm is advance the catheter or advance the guide wire. When you place the catheter and you remove the guide wire, sometimes advance the microcatheter. Also, the hyper pressure of the coil, imperinflated balloon, or hyper pressure in sense. This is the reason every time I have the balloon remodeling support to help me in the procedure. In 1997, Moret related the complication to the technique is a favor, but intraoperative rupture in this study is 1.5 mortality at this time, and 33. Now this is intraoperative rupture of aneurysm in general, and morbidity. With balloon, decrease this. This is one example of rupture, of coiling. You place the balloon and you place the coil. This is another patient, is not bleeding story, young patient, MCA aneurysm. This is a case. Small aneurysm is, of course, this aneurysm is to open surgery, but I don't know why the patient decide to treat it by endovascular approach. Endovascular treatment. Start in 10 o'clock, 20 minutes. I'm coiling 10 and 48. The coil is too bigger. And this is the coil going out in the artery, middle cerebral artery. This is the balloon, guide wire and balloon. This is the coil, and some loop part of coil going here. When remove the coil, the catheter advance. And the patient bleed, a small bleed. This is the bleeding, distal part, 11, during procedure. And my colleague inflate the balloon, but I inflate the balloon too much and rupture the middle cerebral artery. This is the rupture of the middle portion of the M1. At this moment, I inflate the balloon in the terminal part of the carotid siphon in this point. Check contralateral injection with the left carotid to check to stop the bleed. Continues the bleeding, the contrast is here. I inflated a new replacement the balloon to this part, to preserve the anterior choroidal artery. Not bleed. I place in angio suite external ventricular derivation. When the balloon is deinflated, the patient have a new bleed in this part, and this is false aneurysm, dissecting. This is the bleed, this is dissecting. I decide the reconstruction with a stent, and this is the reconstruction of the vessel, but still a little. This is good, but few minutes later, have a new extravasation and dissection in aneurysm and growth. A few minutes later, growth. I decide at this moment, close the middle cerebral artery if the origin and preserve the anterior choroidal artery, have a poor collateral circulation. This is the final control of also craniectomy, decompressive. And this is 6 months, 1 week later, CT scanner. And this is 2-year MR control with infarction, left arm hemiplegia, leg paresia, walk with height. A fusiform aneurysm in middle cerebral artery, a small fusiform aneurysm. This is a case, probably the flow diverter is possible to use. This is oblique projection. This is the fusiform M2 aneurysm, AP view. I use every time one grid wire and the second to place the baby silk material. This is the baby silk place. And this is the control. Few months later. This is the only good result. This is the CT scanner, initial CT, angio CT. But sometimes the test occlusion balloon is possible to sacrifice the artery. This example, this is a high giant aneurysm come in my hospital to treat, but 1 week later, a spontaneous thrombosis because unopened the collateral circulation. Probably is decreased slowly in 1 week difference. Another fusiform aneurysm. This patient is treated by myself in Cartagena, Colombia. I decide to treat it only with coiling in the origin of the aneurysm. And this is a collateral circulation without symptom, without deficit. Finally, I present a rupture aneurysm with after web implant and the management of complication. This is 61-year-old, asymptomatic, not bleeding. This is the aneurysm, large neck, branch born inside in the neck. Probably it's not good to treat it, but it's my first case, and the proctor come will help me. I decide this is good case. No, I don't know. Okay. This is working projection. The catheter, guide catheter. And when I place one guide wire here, and the second with the coil, with the web here, and during the deployment, the web move, the patient bled, small bled, but this is the control angine immediately, high rupture. Very quickly, my friend compression, then manual compression of the neck, and place a balloon in middle cerebral artery, inflate the balloon to stop the flow. This is the web, no detached. And in lateral view, the web is outside the sac, is in subarachnoid space. I decide to replace the web, advance the balloon, inflate the balloon, finally, I place one atlas stent, and this is the web inside. This is the remnant of sac. This is a CT angio suite. You see here in axial view, the atlas stent, the web is not totally open, distal part. This is the final control. This is 1 year later. Some better reconstruction. In 2005, the remnant is stable and the patient don't like to treat it anymore. And the patient is total asymptomatic. This is the control also with magnetic resonance 5 years later without ischemia or deficit. Thank you for your attention. If you have a question.
Assalamu alaikum. I am Major Maimoona Qayyum from Pakistan. I am also a gynecologist. I want to ask a few questions related to a case that was that we received a day before yesterday. We received a patient. She was 37 weeks pregnant. She had previous 2 cesarean section. In her previous cesarean section, when the spinal anesthesia was given, There was a bleed in the spinal canal that was, however, tackled and that appeared as an emergency. After the cesarean, when the CT scan of brain was done, it was found that the basilar artery has an aneurysm. She was advised for the surgery. Till that time, I don't know the surgery. Today, I understood the different method that you have showed in these lectures. And she was advised that she should not produce any more children and she should get the treatment of her aneurysm. But the patient did not obey the medical advice. And now she reported again at 37 weeks with aneurysm and she came for the cesarean section. At that time, we discussed the case with the anesthetist, with the neurosurgeon, and also with the hematologist and vascular surgeon as well. They said it is not possible at the moment to do anything. Once her surgery is done for the cesarean section, then she can be treated. But previously she has raised blood pressure, and this time she also has raised blood pressure. It is decided that the whole team is going to operate after taking a high risk consent. What is your advice in such a case? How should we follow up, and what are the problems that we can have during surgery, during cesareans? Because I am a professor, I teach the students, I teach my postgraduate trainees. So I want to have a knowledge about obstetrical angle so that I can teach better my trainees and my students.
Just, do you want a comment?
Yeah, I want your comments. The advice which is required, and the if we receive such cases in emergency, and if since I am working in Pakistan Army, at that time we are posted in some small stations, and people report in an emergency. In such a situation, how should we handle the case? Being a gynecologist, being
Thank
an
you, ma'am.
obstetrician
Thank you,
and
ma'am.
gynecologist.
Thank you.
So the problem is the patient has a basilar tip aneurysm. Did I correctly understood? Yes.
When she reported first time, it was not diagnosed. Later on, CT scan reported she
Okay,
has.
thank you, ma'am. Thank you, ma'am. Okay, go ahead. You want to comment on this, or should we move on?
I think that what she said, that the patients have 5 months pregnant and she was found basilar tip aneurysm.
Yes.
She was
So
at,
with
she
your
was not 5 months pregnant. She was 9 months pregnant. 37 weeks. She was.
Okay, so 7 weeks, 9 months, right?
37 weeks, 9 months.
Okay, 9 months, and she have so she found that she have a basilar tip aneurysm. Does it rupture or non-rupture?
Still, in the previous operation, she had a small bleed, but at this time she reported in an emergency again, in spite of the counseling and all that, that she should get operation and she should not produce, but again she reported in an emergency.
So
with all previous paper in her hands.
So the aneurysm have already been secured by the surgery, right?
No, it was not secured. It was only diagnosed.
Ah, okay.
Okay, no, I needed the angio diagnosis, but it's different. It's different. The time of treated is depending. If you see the aneurysm, it's possible have MR to diagnose. angiomar, and you see the morphology of these aneurysms, and then you decide, see the patient is bleed, is not bleed, and then you decide, see what is the best treatment. If you like, it's possible angioendovascular treatment, or you go into the open surgery. It depends of the morphology, localization, and see the patient is bleed.
Okay, thank you. Okay, Warwick, let's move on.
Okay, so is there any other questions from the panelists?
Luis, thank you. This was a very nice presentation, especially the challenging cases and difficult moments in the angio suite. I can understand. So it's nice what you showed. Concerning the web, you think it was the tip of the web that kind of peeked through the fundus of the aneurysm, you think, because it was it twisted like that? So it was basically the tip, or what do you think exactly what happened there?
I think it's the tip. For me, the tip is a dagger because it's very stiff, the support of material, and the small movement is it's possible to rub the aneurysm with one coil or one guide wire, but the tip of the web is very stiff. Also, when open, is like a very high movement. But I think that the web device is only for special indication. And my critical point is you are many recurrence of the neck.
Yeah,
is my opinion.
No, the same rupture issues. I don't know exactly the numbers, but that was told by an American neurosurgeon that was not reported. That were not cases from the Webbit trial, because there was only one patient with that had a later thrombolic complications. The results were very good, but that after the Webbit trial, everybody thought it was so safe and easy, and so that probably they were a little bit maybe liberal in using it, and the way they used it, that they saw after the trial ruptures, intraprocedural ruptures, because maybe people were too enthusiastic pushing the web into the aneurysm, and it's so that's something that was not described in the earlier trials, but you see it, yes.
Yes, and I think in the community, in the neurointerventional community, have a discussion is not is stupid discussion. The reason to treat it with the web is because don't use the antiplatelet therapy, and this is not total true, because in acute phase, when you close the aneurysm with coils and then you place for example, Atlas, later it's possible to inject the antiplatelet, intravenous antiplatelet, and treat the patient with antiplatelet. I don't have problem from this. And I think the risk to treat it with one device, a stiff device, with web or another endosaccular, is most easy to treat it with the standard technique, coiling balloon or Atlas, whatever you want, is my opinion.
Yeah.
Okay, Warwick.
Any other questions from the panelists?
Do you use always balloon in any aneurysm, or?
Yes.
Always, so like 100% of the cases.
Always. More than 95%.
Yes. And which balloon now? Which balloon is your favorite one?
The
Transform maybe, or Scepter, or?
No, Scepter no. Standard balloon of ball balloon or probably balloon. And when I don't possible to go far, distal to aneurysm, I place the balloon in the middle cerebral artery to protect in the case I have ruptured aneurysm.
Yeah.
So only for this.
Thank you. Good.
And without heparinization.
Yeah, go ahead, Juha.
Just concluding, it seems to be hard contact sport. Whatever you do, those who have no complications are not doing anything or cheating.
Yeah, I agree.
Totally.
I think we can end it, Rolex, on that note.
No, I still in the learning curve. So yeah, I have a few rupture in my hand a few couple times. Still have to get used to that.
Juha, the next session, I like to talk, if you want, of the cerebellar aneurysm and middle basilar aneurysm. O sea, basilar aneurysm and cerebellar. Restricted.
Big aneurysms?
No. Every. Cerebellar and basilar, small aneurysm.
I don't catch it.
Yes, you are cerebellar, you are pica, no?
Okay, vertebral pica. Oh,
Vertebral pica and middle basilar, you know,
mid-basilar.
middle small basilar aneurysm. No dissecting. Standard aneurysm.
So we have to come to conclusion what we speak. Below the lower part of the vertebrovascular system or not, I think we have done basilar tip aneurysms we have done already.
Below you take that.
Okay, we can talk about that later. Juha.
Okay.
Okay, so if there are any other questions from the panelists, thank Professor Juha, Dr. Luis, Dr. Beans, Dr. Jaws for the really great and presentations today. Is really amazing, and thank for Dr. Bin Su for the simultaneous translating to Chinese, and thank for the panelists audience, and especially the Chinese audience. And hopefully we will meet for the next sessions in which it will be interesting as well and really helpful for like freshman neurosurgeons like me, especially vascular. Okay.
Thank you. Bye.
Bye.
Thank you, everyone. Great job, Warlix. Thank you.
Thank you, John.
Thank you, Juha. Thank you, Louis.
Oh,